Hello, and welcome to the CAP Today webinar for Tuesday, September the 7th. I'm Bob McGonnagle, the publisher of CAP Today, and I'll be your host and moderate a Q&A session after our formal presentations. Today's webinar is entitled Urine Drug Screens, In or Out, the Importance of Drug Screening from Diagnosis to Recovery. Our webinar today is made possible by a special educational grant from Siemens Healthineers. We're very grateful to Siemens for their help and support to bring you this important program. And our speakers, and I'll say a little more about them shortly, are Vipin Adhlakha, who's the president of Aria Diagnostics, and our principal speaker will be Dr. Kednerlin Dornevil, who is the laboratory manager at Soros Clinical Solutions in Massachusetts. But before we begin, as usual, I think a little housekeeping is in order. First, you might wish to refresh your browser. I want you to know that we have live operators standing by throughout today's webinar that can help you with any kind of technical question or problem. There's an 800 number you see at the lower right-hand corner of your screen, 888-364-8804. They'll be standing by to take your call if you have a difficulty. Also, you'll see below the slides a box labeled Q&A. If you have technical problems, you can also type that into that box, and those will get resolved for you. But of course, that's primarily for your comments and questions for our topic today and our speakers. And as I said, we'll take those questions and comments at the very end of the webinar today, and I'll lead a Q&A session with those as the main topic. It's important that you know that you'll get some follow-up email from today's webinar. And also, I want you to know that we plan to post all slides and audio in about a week at captodayonline.com. That way, you'll be able to see this again. You can also share this with colleagues, and people find it very, very helpful. So you can see it there. My last comment is, as usual, I want you to know that the CAP Today does not endorse any products or services that may be mentioned in today's webinar. And any comments of mine are purely personal and obviously not to be taken as policy of CAP Today or the College of American Pathologists. And now we'll begin, and we have a short introduction from our first speaker. Dr. Vipin Adhlakha is in Indianapolis, where he's the president of Aria Diagnostics, and I'm going to invite him to make his remarks now.
Thank you, Bob. Thank you for that introduction, and thank you for providing this great forum for us to share information. I would also like to thank Siemens for inviting us to discuss our experience with them, as well as our experience and successes with our analyzer program. I'd first like to talk about the organizational structure that we've developed here over the last 6 years. Soros Clinical Solutions was founded in early 2015, and through the past 6 years, we've acquired a series of laboratories that are regionally placed that have allowed us to provide faster and better turnaround times for our clients utilizing Siemens analyzers. So we currently have 2 AU680s and 3 Viva analyzers, which we've placed at client sites. And before Dr. Dornevil gets started with his presentation, I do want to point out how we're utilizing those analyzers at these client locations. Obviously, the most important aspect is the improved patient care. Placing these analyzers like the Viva E, which is a desktop analyzer that fits perfectly into these pain management offices and other specialty clinics, allows our providers to offer very, very good turnaround times on their urine drug screens within hours, and that allows them to order specific confirmations, which we appreciate as a reference lab because now we are running the confirmation tests that are unique to that patient, making us more compliant and avoiding any legal hurdles for over-testing. The other real important aspect here is that we've been able to establish partnerships with our clients through these analyzer programs and utilizing our resources such as Dr. Dornevil, who serves as the lab director for 3 of our client analyzers. And then lastly, I just want to mention that the partnership with Siemens has been great. They've identified additional opportunities for us, whether they're new tests on our existing platform or presenting us with new platforms that would allow additional value to our current clients. So I just wanted to mention that and appreciate it and not take any more time from Dr. Dornevil. So Bob, I will hand it back off to you.
Vipin, thank you very much. I appreciate that nice introduction. And now we come to our main speaker. Dr. Kednerlin Dornevil is a PhD in biochemistry. He received that degree at Georgia State University, and he's currently the laboratory manager at the Soros Clinical Solutions Laboratory, LLC. As I mentioned, that's based in Massachusetts. He's got a fascinating presentation for you, and with that, I will ask Dr. Dornevil to go ahead and begin.
Awesome. Thank you, Bob, so much for that introduction. It's a pleasure to be here today. I want to thank Kat, first of all, for setting this up. I also want to thank Siemens for sponsoring this talk today. And I really want to thank the audience for being here and being interested in this topic. And I hope that by the end of this talk that you guys have found something to take away, some things to consider, that if you're considering going into urine drug screens or implementing this in your practice, in your clinics, that you guys have some valuable information that you could take back to your clinics. And so with that being said, let's get started. So this talk is organized into 4 different sections. The first is overdoses. We're going to talk about the current state of the opioid crisis and the impacts that COVID-19 had on drug overdose deaths in the United States. The second topic is the importance of drug testing and its application in a variety of clinical use cases, such as rehabilitation, treatment, so medical-assisted treatment, pain management, and pediatrics. The third is the possible paths to get started with urine drug screens. So the differences between in-house and sending out, and some of the pros and cons regarding the different approaches. And finally, we're going to close it off with some technical considerations for drug screening. So assay selection, quality control, the importance of instrument upkeep. And like I said, the goal of this talk is not to necessarily give a deep dive into any of these topics, but to really provide a broad understanding of what urine drug screening can do for you and some ideas to consider when you're getting started. So if I've done my job correctly, I hope that you leave this talk with a little bit more appreciation for how urine drug screening can help your medical practice and the patients that you work with. Give you some questions to ask when you're setting up, when you're trying to implement UDS into patient treatment plans. And finally, at the end of this talk, I hope that each of you can answer this question. Are urine screens in your future? But before we get started, I want to see if Zoltar can make a prediction for us. So your future is bright yellow. So not the exact answer I was looking for, but I do think that's a positive signal. So with that being said, let's get started to the main talk. We cannot talk about urine drug screens without talking about the drug overdose epidemic in the United States. And I think the key question for today's audience is, Where are we on that front, and what can we do about it? To that end, I've decided to put some numbers together to show why this is such a troubling issue in America. So in 2019 alone, this is 1 year before COVID, we had more than 70,000 drug-involved overdose deaths. Since 1999, the trend in overdose-related deaths has been going in the wrong direction, and that's what gotten us to the point that we are today, where this is such a huge epidemic. And we can also talk about the monetary impacts. So the economic burden is estimated to be more than about $78 billion per year. And that comes from the cost to treat patients, the lost productivity from not working while you're getting treatment. Some of the individuals that abuse drugs are more likely to be involved in the criminal justice system, so costs associated with that. And there's other ancillary costs related to addiction that really makes this a very expensive problem that we should try to resolve as quickly as possible. And I think finally, the statistic that really puts into focus why this is such a crucial problem is the more than 840,000 lives lost since 1999. And that number is actually closer to 1 million now if you include the deaths from 2020, and we're still in 2021, but the numbers from 2021. And with all being said and told, this has really been an enormous impact on current society. It's impacted families, relationships, and it goes deeper than that. And we're not going to know the full extent of the harm of the drug epidemic for a couple of years now. But I was saying the drug epidemic, but it's not really the drug epidemic. We really call it the opioid epidemic, and there's a reason for that. And you can see at around 2015, 2016, there's been a huge and rapid increase in the proportion of drug deaths related to opioid usage. Since 1999, there's been about a 6x increase in opioid-specific related deaths. 70% of the deaths in 2019 involved an opioid. And of those deaths, 73% of them involved synthetic variations of opioid, such as fentanyl. And this huge rise in opioid-related overdoses is primarily because of the use or the increased use of synthetic opioids like fentanyl. Fentanyl is about 50 to 200 times more potent than the naturally occurring opioid and poppy. And because of this, and the fact that obviously street drugs are not known for passing strict quality control specifications, you never know exactly what you're getting. So when an individual is abusing drugs, opioids, and they buy something from the street, it's possible that fentanyl can be mixed in. And when you take the same quote-unquote dose that you're used to taking for that same high, if fentanyl is mixed in, the effect is much more pronounced, and that's where we get the overdoses. And it's not just the strength of fentanyl and the opioids that's causing the problem. There's also mixing effects. Other drugs that are abused have increased overdose death rates when you combine them with opioids. For example, benzodiazepines. You can see here that the death rate more than doubles when you take, as opposed to taking benzodiazepines without any opioid, when you take them in combination with synthetic opioids like fentanyl. This also applies for cocaine. You can see that there's an elevated rate of drug overdose deaths as when you compare the taking cocaine without any opioids, looking at the baseline level, but when you combine cocaine with synthetic opioids, you see a sharp increase in the rate of overdose-related deaths from drug abuse. And unfortunately, the numbers get much worse when COVID comes into the picture. In 2020, we saw more than 93,000 deaths related to drug overdoses. And this is really significant because this is the largest year-over-year increase since 1999. We saw a 30% increase from 2019 to 2020 in regards to drug-related overdose deaths. And when we break it down into the individual drug categories, we saw significant increases there as well. So, for example, cocaine increased by 21%, stimulants increased by 46%, but the biggest jump we saw was opioids, which saw a 54% year-over-year increase in drug overdose deaths. And as we know, COVID has had a huge impact on Americans in all walks of life. It's impacted every single state. And we can see in this map here that the increase in opioid-related deaths for nearly all states in the United States of America has increased relative to 2019. And really, to just summarize the numbers, 2020 has been one of the most significant years when it comes to the opioid epidemic. Compared to the past several years from 2015 to 2020, 2020 has seen the largest increase in drug overdose deaths, primarily attributed to COVID. And we can also break down these numbers based off of the demographic distribution. When we look at it much more carefully, we see that men were hit much harder than women, with a 34% year-over-year increase compared to women, which had a 22% increase in drug overdose-related deaths. If we break it down by age, we see that 15 to 24-year-olds saw the single largest increase at about 50%. And I thought this trend was actually pretty interesting because it actually decreases with age. But we know with COVID, your risk of more fatal infections increases with age. So one of the ideas that I think regarding this is it's not likely due to comorbidities from catching COVID, but more likely from other effects, such as the social effects from the lockdowns and the isolations in 2020. And when we break it down by ethnicity, we see that every group was impacted, with Black, Asian, and Latin and Hispanic Americans having a greater disproportionate impact compared to their white Native American and Alaskan Native counterparts. And for these trends, I suspect that there's multiple variables commingling to get these trends that we see. And it's going to take some time for all the data to come in to tease out exactly how COVID has affected the opioid drug crisis in regards to the different demographics in the United States. So what can we do about this? And I think you might know where I'm going to go with this, because this is a talk about urine drug screening. And I believe that urine drug screens actually can play a very powerful role in combating the opioid epidemic. The benefits of urine drug screening come in many forms. The first is that it allows us to meet the patients where they are. So instead of a one-size-fits-all approach, we can move closer to personalized medicine by getting metabolic profiles for each individual and understanding how they're progressing through a treatment plan allows us to make personalized recommendations to help individuals recover if they have been abusing drugs. Information that we can get, we can assess drug metabolite levels in patients to understand that if we're giving them the optimal dosing required for therapeutic treatment. And we can also use urine drug screening to determine patient risk levels. As I mentioned earlier, when you're abusing one drug, say benzodiazepine, that puts you at one risk level, well, one risk category. But you can, when you combine that with opioids, that actually puts you at a new risk level, at an elevated risk level, because of the mixing effects of having these two drugs. Other questions that you can ask is the treatment plan effective? Is it working? Are they following it? Is the medication being taken as prescribed? So these are some questions that urine drug screening is going to allow you to answer. And like I said, depending on your patient population, who you're trying to treat, drug screening can provide valuable information to help you answer questions regarding how the treatment is going and whether changes to their treatment plans are necessary to meet their goals. So in pain management, questions like, is this current prescription dosing sufficient to meet the patient's needs? Are they going to get the therapeutic benefits at that dosage? If this is a long-term monitoring plan, you can get historical metabolite levels, so the data collected over multiple urine screening events. This can inform the physician on how the patient metabolizes a specific drug. And from there, you can look at things such as, is there elevated levels of metabolites in a patient urine? So are the levels elevating? So that could suggest, for example, that you're taking more than they were prescribed. Or is the concentrations lowering? Sometimes patients don't always follow the exact prescription dosing plan prescribed to them by their doctor. So this will give you some indication on how well they're following the prescription dosage for their medication. In rehabilitation, you can ask questions such as, how likely is this patient going to have relapse? Or how much progress are they making through the recovery program? Certain recovery programs usually have a time period for how long you should stay sober for in order to see some progress. So urine drug screens will allow you to see if that patient has relapsed or if they're able to stay clean and not use that drug for an extended period of time. Other questions is drug-drug interactions. Again, this is a big one. As I've shown previously, opioids, when being abused with other illicits, really elevates your risk category. So one patient that's abusing just amphetamines is actually going to be at a lower risk category than a patient who's abusing amphetamines and opioids. Or if a patient is being prescribed a medication for legitimate use, but then you need to prescribe an opioid, that's going to give you some idea that you might need to monitor their progress more carefully. Other things that you can get are critical values. So is a patient reporting very highly elevated levels of a metabolite in urine? So that could suggest elevated use of a drug very recently, and so they might be at risk of overdosing if that trend continues. And the last group of clients that urine drug screen is very valuable for is in the pediatrics. So 2 million toxic exposures occur each year, and half of them come from children that's younger than the age of 6. And that makes sense. Toddlers usually like to explore their environment, and they'll put random things in their mouth. So urine drug screening, not just for drugs, but can help to identify toxic chemicals that they might have been exposed to. And this is important because when newborns, toddlers, they're so young, their metabolism, their kidneys function differently, so there's potential for short and long-term consequences from fetal drug exposure, iatrogenic exposure, and alcohol exposures. But if you're deciding to get into pediatrics, one thing to consider is how to collect samples. Compared to an adult, adults can autonomously provide that sample, but with children, sometimes you might need to go a different route, such as catheterization or neonatal hair, placenta tissue, or meconium. So you might have to use a different sample collection method to do drug screens. In that case, it's not urine, but it's still drug screening process. One thing to consider, though, when working with pediatrics is an increased chance of false negatives. So in children or newborns, urine is going to be more diluted. So you're going to have to consider the cutoffs that you're using. The cutoffs for pediatrics will not necessarily always be the same as the cutoffs that you're using for adults. And finally, because of the legal ramifications of positive tests, you're going to want to have access to confirmation testing. Urine screens is called a screen. Because of the potential for false positives and false negatives, you want a higher quality standard of data before you can make certain decisions. And so having access to confirmation testing is important if you're deciding to go into pediatric urine drug testing. But really, the number one question at the end of the day is to ask, is our patients getting better? And when it comes to working with patients, the number one thing we need to ask is, are they getting better? How can we leverage different technologies and healthcare processes in our treatment plans? Can we find cost-effective methods to monitor patient progress? Can we make sure that our patients are spending less time in the healthcare system, so less time with us and more time with family and loved ones? And are we improving patient outcomes? So whatever it takes to answer those questions in a positive way is something that we want to look at very carefully and consider very carefully. So if we've decided we wanted to do urine drug screening and it's going to benefit us in our ability to treat our patients, there's several different testing pipelines that we can consider to implement urine drug screening. The first is Waived point-of-care testing. So with that, there's several benefits. The first is testing personnel doesn't require any real clinical lab training because it's really one system. You add the urine to the cup, you close it, and you read your results. So it's easy to implement. But easy to implement does not mean it's actually easy to interpret or diagnose because you only get a qualitative response. So yes, the patient is positive for the drug that's being screened by the quick cup, or no, that they're not positive. So you don't get any quantitative information that would allow you to answer some of those questions that I mentioned earlier. But there is value for quick on-the-spot testing diagnostics. You have a patient that comes in, you might suspect that they have used recently or they're currently high, and you need to make a decision right away. This is a great tool to get you information right away so you can make a more well-informed decision regarding what you're going to do with this patient right there. But also, again, keep in mind that because these tests are very simple, they're not going to be as robust as validated laboratory tests. So you don't have any information on lot-to-lot variability, or the cutoff levels are also going to be fixed. So if you need either higher or lower cutoff levels, you're going to have to find cups that provide that cutoff level. And not every cup will meet your exact specifications, especially if you're testing for multiple drugs at a time. And finally, you can't really investigate the pre-analytical and post-analytical process. So there are some cons to Waived point-of-care testing using quick cups, but there are also some benefits that make it a valuable add-on to other approaches. Another option is to implement something in-house where you set up an analyzer inside your clinic. And there's several pros regarding going with that approach. The first is obvious. You're going to get faster turnaround times from the patient providing the sample to generating the data and the report with the results of the analysis. The industry standard is usually 1 to 3 days, but that's going to depend compared to sending out the sample to an external lab, whether the lab is in-state whether the lab is next door or you have to ship it across states. The shipment process can take a couple of days for the lab to receive it and process your samples. But if it's in lab, you can sometimes get results back in just a couple of hours. Another pro is that you have greater control and oversight over all the quality control processes. So the samples are collected in-house, they're processed in-house, and so if that's really important for you for testing and running a screening operation to have oversight over every step of the process, this is a good option to look into. And finally, you get much more customization. When you go to a clinical lab, they're going to choose cutoff levels, for example, or the different panels or drugs that they test for based off of their client population, which is going to be multiple different clinics. But as a single clinic, you can really customize the panels and the cutoff concentrations to exactly what you need to match your patient population. But there are some cons. The first is it's going to require some upfront costs for the initial investment to purchase the instrument, the reagents. You will have increased personnel and business complexity. The technician to run the analyzer will need to be trained. The office, if your office staff is already has enough work for the clinical operation, you might need to add more office staff to manage the documentation and paperwork to manage an analyzer on site. Another big one to consider is, do you have dedicated space for the instrument? Is your clinic being fully occupied? Is all rooms being fully occupied? If that's the case, where are you going to put the instrument? You might not want to put it in a closet somewhere because things like temperature, humidity, those are parameters that need to be controlled for. And so do you have enough room, and is it well ventilated? And finally, maintenance of regulatory documentation. That's just going to be more documentation work that you would need to do to maintain a clinic in-house. And that's going to be worthwhile if the pros outweigh the cons. So these are ideas and things that need to be considered when you're ready to start implementing urine testing into your treatment pipeline. Another option is external labs. This is where you collect the sample in the clinic and then you send it to a dedicated lab for processing. The pros with this is that the laboratory has extensive expertise and industry knowledge. They're going to have highly trained technical staff. They do one thing and they usually do it very well. So you can be confident that you're going to get good results from them. They can assist in interpretation of laboratory reporting data. Like I said, sometimes the results are easy to generate, but they're not always easy to diagnose and interpret. And that's where having a dedicated clinical lab can help you with that. And finally, a clinical lab can usually provide additional confirmation testing as required. If you decided to go with the in-house, it's not very common, or at least I have not seen it, where a small clinic would have the ability to do confirmation testing on their own. So dedicated external lab would be able to do both the screening and the confirmation as well. But there are some cons. Not everything is perfect. You want to find the right lab. So the location, are they same state nearby? So that makes it easy to transport samples to them, or are they away in another state? So you're going to have to ship samples, and you have to consider how to ship samples to another lab. The quality of the staff, how frequently do they communicate with you? For me, from my experience, I've seen that the best labs are the ones where they view the relationship as more of a partnership instead of one where you just provide a service. Working in the health industry, in the health space, I think cooperation between the different treating groups helps to make sure that you're getting the best outcome for patients. And working with a lab that understands that is going to help you treat your patients. But there are some cons, some other cons. Like I said, you're going to have less control of samples after collection because they do get sent off to a lab. But again, if it's a lab that you trust and that's accredited, you can have a high degree of confidence of how the samples are being handled. And finally, you have fixed panel profiles. So there might not be as much flexibility to really finely tune and tailor the panels to your needs. So in-house versus external testing, how to choose? Well, maybe you don't have to choose. There is a secondary option, which is on-site managed analyzers. That's where you bring the analyzer in-house, but you contract the management of that to a clinical lab to manage it for you. So that's still going to require dedicated space, but there is less to no startup investment depending on the contract with the managing lab. You'll have an on-site technician to collect, process the samples. You're going to have access to clinical expertise from technical personnel, and the clear documentation and all of the documentation and accreditation will be handled by the laboratory manager/director. So now that we've decided the approach we want to take, we can talk about the data that we generate. And I want to show a brief diagram of the clinical laboratory cycle. This is simplified a bit, but the big picture idea is the same. And we could break it down, the laboratory cycle, into 3 phases. The first is the pre-analytical, where you're placing the order, collecting the sample, and then shipping it off. And then the analytical, where the lab receives the sample, processes the sample, and generates a report based off of the results that they get. And finally, the post-analytical phase, which is clinical interpretation, assessing by the physician how the patient is progressing through the treatment plan, making modifications as necessary, and then continuing, stopping, or making some other decision. So when it comes to picking the right test, we're focusing actually on the analytical phase of the laboratory cycle. When it comes to assay selection, you want to make sure that assays cover the range of drugs typically prescribed to the population. So if you're a doctor and you're doing medical assisted treatment and you're prescribing opioids or whatever medication you're prescribing, you want to make sure that the drugs that are being screened cover that range. Or if it's rehab, you want to make sure that you're covering the drugs that are being used in the local drug scene. And when it comes to selecting a specific assay from a vendor, there's a couple of things that we want to look for. The first is that there's minimal cross-reactivity with over-the-counter medicine. So the last thing we want is for a patient taking Tylenol to be showing positive for some other medication that might not be related. So cross-reactivity is something important to look at, depending on the assay. Can the assay be performed at appropriate clinical cutoffs? So if you have a population group that's primarily using, say, cocaine, you might want a higher level cutoff to make sure that that's going to match your population's usage of that drug. So the assay should have appropriate clinical cutoffs to meet your requirements. Next is you should have equivalent results for different compounds in the same group. So amphetamine and methamphetamine, those are both amphetamines. So your response and your assay for one drug should match the response of assay for the other drug. That way, you can be sure that regardless of what individual drug is being abused or taken, that the data that you're going to get is going to tell you if it's positive or negative, irrespective of the drug that's actually being taken, as long as it's part of the same assay group. And finally, is the test sensitive over a broad enough concentration range? So how low can the test go to how high can you detect concentrations. And that's really important because certain analytical information that you want to be able to acquire in terms of how you treat patients, you're going to need to make sure that your assay is sensitive enough over a broad enough range to get that data to confidently make your assessment. And there are other things that need to be considered, clear requirements, for example, when testing and validating a test in the individual labs, all need to be considered as well. For any lab, whether it's clinical, pharmaceutical industry, or academic research, the data that's being generated is the lifeblood of that lab. And data integrity is something that should be considered very early and very carefully in terms of how you're going to monitor and maintain that process. When thinking about setting up a urine drug screening process in-house, it's really important to start thinking early about how you're going to monitor data integrity. These are some of the most important questions that you want to start answering in advance. How will we validate lab-developed tests before they start being used for processing patient samples? How are QCs going to be reviewed? Will we use Levi Jennings plots, or is there going to be some other statistical method to review our QCs? How will we monitor lot-to-lot variations? And do we have a rigorous method for deciding whether lot-to-lot variations are within the range of acceptability by the lab? And when it comes to QCs, they're so important, I have to say it twice. Levi Jennings plots, this is what I use, they're very good, and this is an industry standard, they're very good at giving you a macroscopic view of what's happening overall, and as well as a day-to-day picture of lab operations. So, for example, in this plot that I'm presenting here, you can see by this fourth run, there is a 4.1s violation. And that should hopefully trigger an investigation to identify, are your QCs failing? Is it because you switched to a new lot? And what kind of actions do you need to take to address possible failing QCs? Instrument maintenance, that is something that is extremely important. And usually that gets overlooked. But we need to pay attention to the instruments that we're using to generate the data for our patient population. So is it worth having a PM contract? Do you have a clear and concise instructions for the general maintenance? How easily can you maintain your instrument? Can you do most of it in-house, or are you going to need to bring in a service contractor every time to maintain your instrument? So in this slide right here, we can see that this balance hasn't received a lot of maintenance love in the past. So if I ask you a question, how much would you trust this balance to weigh out a chemical or something? Do you have an answer for this? For me, the answer is no. You don't use this balance, right? I would be very skeptical with any data that is generated from using this balance. Balances are very, especially analytical ones, they're very sensitive instruments. So something as kind of gritty and clean and uncapped as this one, depending on the assay, depending on the level of sensitivity that you want, your results could be very different from what you're expecting, and that's going to lead you to make the least optimal decisions in regards to treating patients. We're in the clinical diagnostics and healthcare patient improvement space. So the data that we generate, it really plays a critical part in helping our patients get better. And I think we would be doing them a disservice if it was generated on an instrument like this one. And so really, I think the key takeaways from this talk is that the surge in opioid usage in the past 5 years has really contributed significantly to increased levels of related drug overdose deaths. And not just opioids, but the introduction or the increasing use of synthetic opioids like fentanyl. when it comes to COVID-19 in 2020, we saw the single largest year-over-year increase in drug-related overdose deaths. Some trends have some patterns that can be discerned, but really we're going to need more data to really find out what the full impact of COVID-19 has been on the opioid epidemic. When it comes to UDS drug screening, there's a lot of flexibility in terms of how you can monitor and track patient progress through rehabilitation or medicine-assisted treatment plans. And there's a lot of questions that you can ask and are able to answer with the help of drug screening. Drug screening offers a variety of strategies for healthcare providers to implement into their workflow, whether it's in-house or external labs or point-of-care testing. So there's a variety of opportunities depending on your needs for your patient population. And finally, proper implementation of the UDS pipeline requires technical consideration of assay selection, proper instrument maintenance, and QC/QM monitoring. And hopefully, I've given you guys just a little bit of something to think about if you've been interested in implementing urine drug screens in your clinic, whether it's in-house or an external lab partner. And with that being said, we have reached the end of the talk. I want to acknowledge the College of American Pathologists, CAP, for setting this up. I want to acknowledge Seaman Healthineers for their sponsorship and their grant and providing the opportunity for this talk. And finally, I want to thank the audience, you, for being interested in this topic and looking for ways to try to improve the healthcare options or the healthcare outcomes for your patients. And with that, thank you guys, and I'll take any questions.
Dr. Dornevil, thank you very much. That was a wonderful talk. I'm going to put back the key takeaways so our audience can look at those. And while I give you a chance to catch your breath, let me remind folks we have a brief left. So if you have a comment or a question, please feel free to type it in to the Q&A box below the slides, and we'll take as many as we have time for today. We've gotten several questions, Dr. Dornevil, around essentially qualitative screening as opposed to quantitative screening. So first let me ask you, what would be your advice if a laboratory person decided that they'd like to use rapid screening strips in this process of treating patients for opioids, etc.? How would the rapid screening strips fit into a laboratory portfolio, in your opinion?
Yes. So for me, I think the rapid screening strips, the quick cups, have their place because of the ability to get information very quickly, right? It's in their name. So I would not use these exclusively to an analyzer or some confirmatory testing, but to get some quick results if you need to make a decision right away, but you can't wait 6 hours or a day for the turnaround time to, confirm. I think that's where they are really helpful. You use them in combination with an analyzer.
Yes, thank you. And another question just on that same line, if you'll just expound a little bit further, how you monitor urine drug concentrations when you're performing point-of-care tests.
So that was one of the cons. You actually cannot. I'm sorry if I wasn't clear. So one of the cons with that is that you only get a qualitative response, yes or no. If you wanted more quantitative information, you would have to use an analyzer and set it up to perform the test quantitatively. So you have several options when you're doing screening, either qualitative, where you just get yes or no response, semi-quantitative, where you get a number, but you report just yes or no, whether a cutoff was met, or quantitative, where you get an accurate number, of metabolite levels in urine.
Thank you. Thank you very much for that clarification. We have a question from one member of the audience. Are all the tests that you're running on these platforms FDA cleared?
Yes, yes. So all these tests will be cleared by the FDA, and they will be validated in-house in the lab to make sure that they meet the specifications that were generated by the manufacturer.
Very good. Thank you very much. And we have a very interesting question here, at least to me, and several others have asked the same one. Does fentanyl react with opioid qualitative tests?
Fentanyl does. So that's a very good question. So for qualitative testing, you will have some cross-reactivity, but that's where confirmation testing, so LCMS, comes in. You can't really distinguish between the individual drugs within a drug group. All you can say is that the patient was positive for that group. So whether they were positive for opioids or just positive for amphetamines. To get more specific information, like what they're positive for, you're going to need to do confirmatory testing such as LCMS.
Very good. Thank you. And of course, given this audience, there's a lot of concentration on samples. The question is, should samples be tested for temperature, specific gravity, or pH in search of adulteration? And in other words, how do you also see integrity checks as part of the evaluation of the specimen that you receive?
Yeah, so that's a good question. That's one that's going to depend on the patient population. So if it's rehab or if it's just monitoring, medicine-assisted treatment, and depending on how the sample is collected, is it observed collection or is it non-observed? In our lab specifically, we do pH, we do oxidants, and we do creatinine. We don't do specific gravity, but that's because our collections are observed. And we think that that's actually sufficient for our needs, but for your clinic, you're going to have to kind of decide, depending on your patient population, what are the chances that you're going to have a patient trying to manipulate and modify the integrity of that sample before it gets run.
Thank you. Thank you very much. One more question back to fentanyl, really a follow-up to an earlier question. Does a negative opioid qualitative result exclude the presence of fentanyl?
Does a negative
opioid qualitative result exclude the presence of fentanyl?
I can't answer that. I would have to do a little bit more research. Off the top of my head, I cannot remember, but I can definitely get back. Maybe I can reach out to the CAP and provide that answer, but I don't have that answer right now, unfortunately.
That's certainly understandable, and we will try to get that for the questioner. Thank you very much. Now, let me ask you, this is a little bit of a social and legal and to some degree a personal opinion, but many people are interested in your take on this. How many times should a patient be allowed to fail a urinary drug screen before being dismissed from their practice? I guess that means the job, or referred to an addiction provider. Do you have an opinion about that?
That's a very tough question. It's really going to depend on the patient and the clinician. Personally, for me, my objective is to do whatever I can possible to help individuals get better. And I have the understanding that people are going to make mistakes. Addiction is very difficult. It's very challenging. I don't think people necessarily choose that path willingly, So when individuals fail, it doesn't mean they're not trying. And for me personally, and this is not, advice, but I believe the most important thing is the patient making a real effort to get better? And if they are making an effort, a real effort, and deliberate one to get better, I think the least we can do is be there with them while they're going through that process.
Very
and I
good.
don't have a number per se, yes.
Thank you very much for that. I'm going to leave that with you as the final answer, the final remark today. We have a great deal of traffic, lots of opinions from participants, etc. And thank you very much, Dr. Dornevil, for illuminating this very murky and troubling element of society, which is the opioid crisis, which I know we all read about and hear about, but this has been a fascinating session that you've provided for us. So with that, let me begin to wrap up. I'd like to thank Vipin Adhlakha from Aria Diagnostics for a very nice introduction. Obviously, Kednerlin Dornevil gave us the main speech today, and you can see his slides and hear his audio in about a week at captodayonline.com. And then I would also, of course, like to thank Siemens Health and Ears. It's their educational support that enabled us to put this program on, and we're very grateful for their help. And I'm sure all of you feel this has been a very, very worthwhile session today. In addition to that, I would like to thank all of you in the audience for taking time today to be with us for this very important program. And so with that, once again, I want to thank Dr. Adhlakha, Dr. Dornevil, the audience, and Siemens Health and Ears. This is Bob McGonnagle, and I'll now bring this webinar to a close. Thank you very much.